to start this. So everyone hear me now, I guess. So hello, and first of all, I want to thank every one of you for joining this symposium, because I noticed that we are more than 250 people, so thank you for your interest. So in this presentation, we're gonna talk about the main hematological abnormalities that can be found with COVID-19. So we're gonna start with the case report that happened in one of our lab partner hospital in the University Hospital of Brugman. So it was just at the end of the Belgian lockdown, where a 58-year-old male presented himself to the emergency department for trouble breathing. On his background, he had just a chronic obstructive pulmonary disease, stage GOLD 2, and hypertrophy benign of the prostate, atrial fibrillation, and obesity. On his admission, he had the oxygen saturation of 86% and without any fever. A chest scan was performed, and we found out a pleural effusion and 35% of lung surface highly suggestive for COVID-19 infection. So here are summarized the main finding of the lab. So we had a reduced hemoglobin, slightly reduced hemoglobin, a normal platelet and white blood cell count, a severe lymphopenia with 40 lymphocytes per microliters, normal neutrophil count, and a raised D-dimer rise to 3,500 nanogram per milliliter. Of course, he got tested with the PCR for SARS-CoV-2, which turned out to be positive. A pleural tap was performed as well, with the findings are summarized here for the total cell count. So we had the white blood cell count measured to 1,700 per microliters, with the differential count showing 93% of atypical lymphocyte population. And the morphology of those lymphocytes are presented in the picture on the right. So this could be compatible with COVID-19. But the SARS-CoV-2 can wear a lot of masks and can induce pleiotropic abnormalities. In this presentation, we're going to focus on the hematological disorders that can be found with the COVID-19. The hemostasis one will be discussed later today in another presentation. So the main hematological abnormalities in COVID-19 are the lymphopenia, with or without atypical lymphocytes, the neutrophilia, and the thrombocytopenia. All those features are not COVID-19 specific. So the lymphopenia is the most common anomaly found in COVID-19 patients. Wong et al. Conducted a study in Wuhan where they found out that 63% of the COVID-19 patients had the lymphopenia. The lymphopenia is slightly reduced during the incubation period and can be significant during the cytokine storm. That happens usually 7 to 14 days after the onset of the symptoms. The physiopathology of the lymphopenia is multifactorial. So first, we have a direct toxicity of the virus on the lymphocytes, because the lymphocytes has there's something popping up here. What's this? So I said that there is a direct toxicity of the virus on the ACE2 receptor, because the lymphocyte has the ACE2 on its membrane. There is an apoptosis induced by the TNF-alpha, which is a player in the cytokine storm team. There is also a lymphocyte proliferation inhibition induced by the acid lactic acidosis. And finally, there is a lymphoid organ atrophy due to a direct virus toxicity. So this is the quantitative aspect and effects of the SARS-CoV-2 on the lymphocytes of a possible infected patient. But there is also a qualitative one, which is common to all viral infection. It's the findings of atypical lymphocytes. So the atypical lymphocytes or reactive lymphocytes are activated lymphocytes who display a wide blue basophilic cytoplasm. It can have several shapes depending on the immunostimulation state that this lymphocyte is in. And so here there is several pictures of lymphocytes from COVID-19 patients. Beside this picture here, it's from a patient who was infected by the Epstein-Barr virus. And I just put it there to let everyone see that for an unexperimented eye, those two lymphocytes, for example, can look quite the same. So now let's discuss about the neutrophils. So neutrophilia usually precedes the increase of the reactive lymphocyte. It's an expression of the cytokine storm and hyperinflammatory state, and it's a sign of, it can be a sign of secondary bacterial infection, which should be kept in mind. So the two main abnormalities affecting the neutrophils of the COVID-19 patients are presented here. It's an hyposegmentation of the neutrophil and the netosis state. So on the left picture, we can see an example of an hyposegmented neutrophil with the metamyelocyte kind of shape for the bottom and the pseudopelgar shape for this neutrophil above it. And so the differential diagnosis with all the conditions that can be associated with pseudopelgar should be considered. Just like a leukemia or a myelodysplastic syndrome with high dysplasia. Then on the right picture, we can see several neutrophils in a netosis state. So the netosis is an activated state of the neutrophil where nets are released by the neutrophil. So the net stands for neutrophil extracellular trap. It's neutrophil DNA mixed with several proteins and then released outside the cell. It's a defense mechanism to fight infections, but this process can be a double-edged sword because it can also act against the host cells, mediating thrombosis and mediating autoimmune disorders. So the thrombocytopenia is a common feature in all viral infection. It's due to an immune destruction, but in the COVID-19 infection, it's due to an inappropriate platelet activation and consumption. We have an infection and inflammation that's going to induce lung tissues and pulmonary endothelial cell damage, which will lead to an inappropriate platelet activation and microthrombi formation. And it's also hypothesized that there is an impaired megakaryopoiesis of a still unclear etiology, that it's maybe a direct effect of the SARS-CoV-2 on the megakaryocytes or a destruction of the progenitor cells due to the cytokine storm. So hematological abnormalities in COVID-19 are not SARS-CoV-2 specific. How can we take advantage of it in terms of diagnosis and prognosis of the disease? So now I'm gonna introduce you two promising tools, which are the Paris score and the NLR. So the Paris score was indeed made in Paris by a French team, but it stands for pretest probability for SARS-CoV-2 infection based on scoring. It was retrospectively determined on a cohort of 100 patients separated in two groups, one group of 50 COVID-19 patients and 50 control patients, and prospectively validated on 300 patients. And so the Paris score use easy accessible variables that we can find with the complete blood count, and following the odds ratio, they assigned points to those variables. And so when the patient had a score of 0 or 1, he was at a low probability of having the infection. When he had a score above 4, he had a high probability. And a score of 1 had been linked to a negative predictive value of 1, and the score of 5 was linked to a positive predictive value of 0.96. So the Paris score has a couple advantages. So it's based on a basic complete blood count. It's fast, affordable. It allows patients with a low probability score to stay apart from those with a high one. It helps avoid useless repeated tests in case of a low probability score. It completes the CT scan sensitivity, which signs can be delayed. And it can also help managing RT-PCR test shortage in developing countries. But if there is good side, there is also bad sides. And so the bad side of it is that we have a selection bias because it was made with a retrospective design. We have a recruitment bias because patients were included from hospital wards and are not representative of the main patients with milder symptoms who consult the GP in the general population. It was built during pandemic, so the performances beyond the SARS-CoV-2 epidemic is unknown. And it's also limited when there is an hematological disease present, like lymphocytes can be high in the leukemia, or with the myelodysplastic syndrome, it can falsely induce a high probability score. So now we're going to talk about the neutrophil to lymphocyte ratio, the NLR. So the NLR, it's easy to get. We get it by dividing the neutrophil rate by the lymphocyte one. But it was initially non-COVID-19 oriented because it was already used to predict the mortality in cardiovascular disease as a prognostic marker in cancer patients, used in sepsis, pneumonia, and acute respiratory distress syndrome. In COVID-19 patients, it can be used to predict the patient that's going to make a severe form and predict the patients who will need more intensive care. So on the study conducted on 344 patients by Aid and his colleagues, they assessed the best NLR cutoff according to age for predicting the need of intensive care. So they found out that for all ages, a cutoff of 3.03 had acceptable performances. Under the age of 50 years old, they found out that the NLR had a specificity of 93% with the lower sensitivity. And above 50 years old, they found out that it had a good performances with 95% for the sensitivity and 93% of specificity, which is interesting because everyone know now that it's the elderly population who is the more at risk of severe outcomes. And then the high sensitivity of this ratio makes it a quick and simple tool with acceptable efficacy for screening patients who needs more attention. And moreover, the high specificity according to the age can also make it a good tool for ruling out the low risk patients. So now let's go back to our patient. So our patient was COVID-19 positive. So should we stop there? Is it a diagnostic catch-all? Like, okay, he had a pleural effusion and COVID-19 with lymphocytes, like looks reactive. So it's just reactive to the COVID-19 infection. Or maybe is there a trap? So yeah, of course, there is a trap. So we performed an immunophenotyping on the pleural tap, and we found out that our patient had an anaplastic large cell lymphoma. So we must highlight that patients having cancer and COVID-19 are at higher risk of severe outcomes. And we know also that among all the cancers, it's the hematological cancers who had the highest death rates. And when we apply those tools that I just showed you to our patient at admission, we found out that he had a Paris score of 5, which is a high pre-test probability of having the SARS-CoV-2, and he had it. He had the neutrophil to lymphocyte ratio very high, above 100, which is a high probability of getting into the intensive care unit, and he got admitted there. And unfortunately, our patient passed away 36 days following admission due to the severity of his condition. So in conclusion, we can say that basic laboratory hematological tests are easily accessible. In the form of a score, it could be useful, but used with caution in the management of a suspected COVID-19 patient. COVID-19 is not a catch-all diagnosis. Cytopenia and morphological cell abnormalities are not COVID-19 specific. It's a common feature of COVID-19 and hemato-oncological disease, and so therefore, the differential diagnosis remains mandatory. So thank you for your attention. Je n'entends plus rien. Je ne sais pas si